Hey everybody, Zach Evans here. I am going to share a video tutorial with you that I think will help you avoid some common mistakes that I see all the time. In the posterior mandible especially, if you have an edentulous span, whether it's unilateral or bilateral, I see the risk with guided implant surgery all the time of the potential for guide unseating with downward pressure in that edentulous space. So especially if you have multiple implant sites, and especially if you're doing the case flapped, you don't really have any guide support in that edentulous space. So let's think of a case, for example, where you have, I don't know, teeth 20 to 28. If you are placing implants posterior, there's not a lot of AP spread, if you that will support the guide when you're drilling. So there's the potential for downward pressure while you're drilling to unseat the guide and force the implant angulation and depth to be inappropriate. So I have this simple trick that I've created, or that I use, I should say, that will help avoid this in the future for you when you're doing cases like this. So let's take a look at this example case. What you want to do when you're planning your case is to capture enough of the intraoral scan beyond the edentulous space, posterior to that space, so that you can use that area for support for your guide. So here we go. We've extended the intraoral scan and the selected area to be covered by the guide to go well beyond the posterior of the site that we're looking at. In this case, the support's probably not too critical. We have lots of teeth to support the guide, but nonetheless, we're going to plan this method to help reduce any risk of guide movement or unseating. So essentially all you do is select a little bit of an area beyond posterior to your surgical guide, and you want a patch roughly a few millimeters square, if not more, and you want the space between the guide sleeve holder and that patch to have a little gap, so you can see how we've erased it to create that space. And what that will do is alleviate the risk of the guide coming unseated by giving you some posterior support. So we're just trimming the guide. I added bars to that patch to give it the support it needs. And here we are, just kind of finalizing our guide design. We'll do another example here in just a minute, but this is the gist of it. Your intraoral scan extends posterior. You have a surface area that's covered. Again, it only needs to be, a few square millimeters. And by adding bars to connect to that, that will eliminate the risk of downward pressure causing the guide to come unseated or to move when you are performing your surgery. So here's the case again. It's site number 19 implant, and we have designed it so that we have some posterior support. Now, when we're looking at our surgery, you can either do the case flapless, of course, or in the case of the posterior mandible, most likely you don't have enough keratinized tissue. So normally what I do is I will create right at the mesial extent of the posterior patch that's being supported. I'll create a little bleeding point right there, and then I'll take off the guide, and then I'll use that as reference for my flap design. So I'll do a little horizontal, like crestal vertical incision. I'll do sulculars on the teeth in front, and then I'll connect that together with a crestal incision, and then I'll flap it. So that way, you know the tissue posterior to your implant is being covered by the guide, and that will eliminate that risk of unseating while you're doing surgery. Okay, let's look at another example in detail. So this is a maxillary case. Again, it's probably not necessary to use this method. It just so happens that these are the implants that I was planning today, so that I'll use these as examples. But you want to plan your implant using just your normal implant planning workflow. And then when you go into your guide design, again, you want to make sure that your intraoral model or scan extends well beyond posterior to the implant site. And you're going to draw your area to be covered by the surgical guide and extend it well posterior to the implant site. So you want to go ahead and skip to show your guide, to preview guide, and you want to start making your trimming and adjustments. So in this case, you want to leave all of that posterior surface area beyond the area posterior to the area where the guide is. So you can see that we're erasing. I like to erase directly under the sleeve holder and then leaving some of that surface area covered by the surgical guide. So again, just trimming the flanges here beyond the undercuts, apical to the undercuts. We don't necessarily need it to extend so far posterior on the contralateral side. Now, you do want to make sure you trim at the literal boundary of the intraoral scan. That way you don't have any artifact of the surgical guide that may not seat correctly. So this is it. This is about all the surface area you need. And then we're going to connect it with 2 bars. And you want to make sure that you have eliminated some of that mesial distal space if you're planning to flap the case. This case, because it's in the maxilla, plenty of keratinized tissue, we might just do it flapless. But if you were going to flap it, you need to make sure you're giving yourself enough room to reflect your flap. So that's it. When you start doing these cases, if you plan and include this little posterior stop, you're going to notice a difference when you're drilling. The guide is just going to feel a lot more stable when you're bottoming out your drill on these posterior implants. It's just going to feel firm and stable. And I especially like it for those cases in the posterior mandible, like I said, where you're doing premolars and molars, especially if you're doing multiple implants. Those are the cases I think that pose the most risk. But this is it. This is a really simple method to sort of hedge your bets and eliminate some of those risks. Whether you're doing it flapless or flapped, this will really help. So in an ideal world like this case, we would be having posterior support from a third molar, but that's often not the case, and therefore having some support, whether it be on the tuberosity or like the retromolar pad, make sure you include that space in your intraoral scan if you can get it, and this will allow you to have this posterior support to eliminate risk, especially in cases where you might be getting close to the mandibular fossa or the mandibular canal, where you just don't have any room for error. Well, thanks. I hope this helps, and look forward to seeing you guys soon. Thanks. Bye.